Welcome, everybody. It's lovely to see you all. This is a basic look at the plain film of, and I make no apology for the fact that this is a basic lecture for a basic course. So what I want to do is to take you through some of the key points about looking at radiographs in musculoskeletal and just making a few key messages for you in the process. Now, the objectives of this talk are to approach the evaluation of the plain film in a structured format. I hope to show you some of the feature-differing responses of bone and joints and soft tissue to disease processes, discuss the differential diagnoses and recognizing the limitations, and finally appreciate the role of plain radiography in the context of multimodality imaging. So if we start with why a plain film anymore, well, they're available. They're easy in every department. You don't need very expensive equipment to do them. And the radiographers are very good at providing the service. So it is the first line of investigation in the majority of situations to do with musculoskeletal diseases. Clearly, in the casualty department, you may go straight to CT in a number of situations, but the plain film is always available, and it's cheap. Standardization, radiographers have a long training, they know the different views, and they can do weight-bearing views, you can do dynamic views very easily, and of course, you can do quantification. And as you all know, orthopedic surgeons love quantification. They'll draw a line or an angle on almost every radiograph they have. So, standard radiographs, the views, I've just put a simple example of a normal lumbar spine. The standard views, AP and lateral, and in some cases a focal view of the lower lumbar spine. The manuals for radiographers are full of standard views for all sorts of different situations, and these can be followed very easily. Quantification, I've mentioned, you can measure all sorts of angles. This particular one is the acetabular index for CDH, and this example of CDH showing you the dislocation is clearly visible, but in some circumstances that may be difficult, and these measurements are of value. So quantification is a key assistance to the diagnostic process. Now here you have a calcified disc on a plain film. You can see it very clearly. But do you? In fact, it is a calcified lymph node superimposed on the disc. And the message is quite clear. Always have two views. Never settle for one view. A fundamental fact, if you take nothing else from the lecture, make absolutely sure that you have two views, at least. Here's another example. You can see that there is a sclerotic focus in the shaft of the bone, just there on the AP. The lateral shows you that it is actually some focal cortical thickening, and then you can go on to your specialist investigations, CT, to show that it is just some benign cortical thickening on the anterior aspect of the tibia. So what information are we looking from in musculoskeletal diseases? We're looking at bone, we're looking at the joints, and don't forget, we're also looking at soft tissues. Despite the fact that we have ultrasound, MR, CT, the soft tissues in plain radiography are still a valuable asset. The other message to take away from this lecture is know your normal anatomy and appearances. If you do not know what the plain film looks like normally, then it's very difficult to make a diagnosis of an abnormality. Here's just an example of a normal wrist with the different views, the AP, the oblique, and the lateral, all giving you different information about the relationships of the carpal bones. And any examination of radiologists, junior trainee radiologists, should, in my view, include an examination to test their knowledge of normal anatomy. So remember, it's absolutely vital. The other thing to remember is that there are a lot of normal variants. Here's just one example, the normal lumbar spine and a limbus vertebra. Now, some might argue that the limbus vertebra is not a true normal variant, but it is actually an apophysis, and it is a variant of a normal normal growth process. So remember your normal variants. There are some very well-established textbooks which guide you through that, and always have them nearby when you're reporting so you can refer to them. Now, probably the most used part of plain radiography still is trauma. And some examples. You know now from your normal anatomy that this is not a normal wrist. And you can see that although on the AP view you may say, oh, this looks fairly normal, it is in fact a metacarpal dislocation. So again, by knowing the normal anatomy, you can make that diagnosis. Look for lines where you may see a line which just doesn't look quite right. Here are 3 different views of the same wrist. I don't know whether any of you have seen the abnormality, but right there, if you look at the epiphysis on the lateral view, the line just looks abnormal. And indeed, when the CT was done, you have a Salter fracture of the epiphysis. Another message, the diagnosis of fractures of the pubic rami here and here is not a big diagnostic problem, but you must also make sure that you have also looked at all the bones, and here you can see this is associated with a subluxation of the sacroiliac joints. So a further message, basic message, look at the whole film. Do not settle your eyes on one abnormality and then feel that you've done the job. This is where, again, normal anatomy is very important. You do a plain film of the foot, and it may look fine. But in fact, when you look at the normal anatomy, it becomes obvious that there is a separation of the carpal bone, the tarsal bone, and clearly this is a Lisfranc fracture dislocation. Very difficult sometimes to diagnose. Look at the soft tissue swelling. If you see soft tissue swelling in this region and there's been a significant injury and you can't see anything, go on and do a CT, because you can be caught out by a Lisfranc fracture. Another well-known feature to look for is the soft tissues and, of course, the fat pads. Now, I'm afraid this doesn't perhaps show terribly well, but with the enlarged view, you can see, there is a fat pad extending. There's also a big fat pad anteriorly, and this confirms what you might have seen in the plain film, that the radial head looks abnormal. But that will tell you that there is a fracture. And there you can see again on the AP view the compressed radial head. Plain films can still be used from the spine, although so many departments go straight to CT. Here you see the classic bow tie effect of the unilateral dislocation and the alignment of the spinal processes being shifted in the upper cervical spine to the right. And so you don't need the MRI. You know that there is a unilateral facet dislocation, but the MRI is useful in order to look at the cord and to ensure that there is no cord damage at this point. One other feature that plain films provide you, as I mentioned in the initial slides, is that you can do dynamic views. And here is an example of a patient, and you can see that you can see the soft tissues look abnormal, but the actual anatomy and the bone looks normal. However, if you then stress the ankle, you can see that there is actually a fracture of the fibula and ankle instability. So here you've got the ability to do some straightforward fluoroscopy or even plain films to provide you with the diagnosis. So, imaging analysis in MSK disease. When we've moved from trauma, where you're looking for changes in the normal anatomy, we move on to disease processes. And the message is there is, what is the disease doing to the bone itself, and what is the bone's response to that disease process? And what I'd like to show you now is just some ways of going through this. Now, when you perhaps pick up a plain film, you may feel, well, how am I going to analyze this? And maybe you feel like Fred. Well, what I hope to do is to perhaps give you one or two messages to help you look at those. And the key here is to look structurally at the different parts of the bone. So you want to look at bone density, the cortical thickness, the cortical outline, trabecular pattern, and the periosteum. So if we move to the analysis, we also need to be aware of what the age of the patient is. Is it a patient with fused epiphyses? Are the epiphyses open? Is there normal periosteal growth going on in a younger child? These are very important. Are the changes localized or generalized? You may have one film which suggests it's localized, but you have to keep in your mind that there may be other areas of bone affected. And again, is there a simple single episode, or are there multiple lesions, which may again not be on the images that you have, and you may require to order other films. So, what other things to take into account? Where is the lesion? Is it diaphyseal? Is it metaphyseal? Is it epiphyseal? And clearly, different lesions may predominate in different areas. But don't use that as an absolute. You may see an osteoid osteoma. The osteoid osteomas may well be commonly in the diaphysis, but they can also be in the joint, as we'll look later. Metaphyseal lesions, again, bone cysts are usually metaphyseal, but they can, as the bone grows, they can move down a long bone and become diaphyseal. Osteomyelitis, again, usually metaphyseal, but may occur within the joint, in an epiphysis, or in the diaphysis. So remember, it is a helpful guide, but it is not an absolute. So what we're then going to look at is bone density. And I first want to look at the loss of bone. And of course, the most common generalized loss of bone is trabecular. This is osteoporosis. And osteoporosis, remember, is a loss of bone. You can see this is the histology of the normal bone with the calcified trabeculae, and this is an osteoporotic bone. There's nothing wrong with the bone, there's just less bone. And this is a microfocal of a patient with osteoporosis, and you can see the absence of trabeculae. You may also notice that there is actually a fracture of the trabeculum with a little callus formation around it. So here we have a normal bone, but less of it. And the classic picture, of course, is the pencil outline of the bone compared to the normal. This is the normal, this is the abnormal, the very sharp pencil line, loss of bone density. But remember that bone density can appear to be affected by the radiographic exposure, so do be careful when you're making a diagnosis of osteoporosis. There is on this one, obviously, the telltale collapse of the vertebra, but if in doubt, then obviously you can go on to do bone densitometry, which will give you a figure to hang your diagnosis on. You may have osteoporosis, but you may also appear to have some sclerosis. And here you can see the sacrum appears sclerotic when the rest of the bones are osteoporotic. This, in fact, is because there are insufficiency fractures as part of the osteoporotic process in the sacrum. So don't be put off by the fact that you do see an area of sclerosis associated with a patient with osteoporosis. Now, osteoporosis, when it's generalized, can be difficult to diagnose, but it's also sometimes difficult to diagnose when it's localized. Here you have a patient who clearly has an osteoporotic hip on this side, and you can see the difference in bone density. The outline is less sharp, and here on the oblique view you can see this intensely osteoporotic head. And this, of course, is transient osteoporosis, well-known diagnosis in pregnant ladies, but it also occurs in middle-aged men, and it is usually self-righting. Another example of focal osteoporosis is in this, where this hip is a little more osteoporotic than this hip. And in this case, there is an intra-articular osteoid osteoma. And remember that intra-articular osteoid osteomas may produce a synovitis, which actually produces a localized osteoporosis. And here you can see a loss of bone density, but the density of the bone, the outline of the trabecular pattern is not very clear. And so you've got to decide what is happening. There's obviously a fracture. This has been replaced, but the bone doesn't look osteoporotic. It looks odd. And the secret, of course, is this, the looser zone. This patient has osteomalacia, and osteomalacia is a lack of calcification of the normal osteoid. So this is the osteoid showing you the lack of calcification, and this is a classic picture. So you can see the difference between osteoporosis and osteomalacia. The pediatric version, of course, is rickets, and here you can see the splayed epiphyses and splayed metaphyses of rickets. So trabecular bone loss, remember that it can be difficult if it's generalized. And so we move on to endosteal bone loss. Now, this patient provides you with another key message. This film looks absolutely normal, but it's not. And the key message is that you may have pain in the hip, you may have pain in the knee, but it may be coming from the shaft of the bone. And in fact, if you look down here, you will see that there is a little endosteal erosion. And if we sharpen that up, you can see there it is, the endosteal erosion in the foot. So what's the diagnosis? Well, later on, you can now see it more clearly, and you can also see that there is a little periosteal reaction related to it, and this is an eosinophilic granuloma. So the message is, again, look at the whole film and beware of some of these little minor signs. Clearly, it is much more visible at a slightly later stage. Inner cortical erosion can be caused by a number of things, but the cartilage tumors, fibrous dysplasia, bone cysts, and Langerhans cell histiocytosis are some of the key features. The next area to look at is intracortical, and here you can see a fibrous cortical defect right in the cortex, a lucency in the cortex. But some of you may notice that there's actually a little sclerosis associated with this. Is this calcification in the lesion, or is it sclerosis? And you can see maybe a little peri-osteal reaction on the edge. And this is, in fact, a fibrous cortical defect that had caused a stress fracture. So again, you've got two diagnoses. You've got to look carefully at the film and think clearly about what's going on. Sub-periosteal resorption. The key area for sub-periosteal resorption is the metacarpals, and you can see here, sorry, the metacarpals and phalanges. You can see this chewed area, which is absolutely classic, again, of hyperparathyroidism and the loss of bone at the tips. So always look at the sharpness of the periosteal line for this. And this just shows you that in hyperparathyroidism, this is a combination of osteoclast resorption of bone and a lot of effort by the osteoblasts to create new bone. So you will get some appearance of some sclerosis as well as the sub-periosteal resorption. And there are lots of sites where this occurs. You can see in the ischial tuberosity, in the clavicle, and in this case, in this young patient, because there's sub-periosteal resorption, hyperparathyroidism, there's actually a slipped femoral epiphysis. Finally, look at the peri-articular region. Here is a case with clear peri-articular osteoporosis, and this case is one of rheumatoid arthritis. There's soft tissue swelling, and you've got a result is an inflammatory arthritis, which is leading to sub-periosteal resorption. Disuse can produce localized osteoporosis, and of course, reflex sympathetic dystrophy can produce very intense localized osteoporosis. So if we move on to bone replacement, here we're looking at lesions which are replacing the bone rather than affecting the actual bone itself. And here you can see the classic position of a Brody's abscess associated with the bone reaction, a sclerotic reaction around it in the metaphysis. And your MRI is simply there to confirm the inflammatory features, but you can virtually make a diagnosis on the plain films of a Brody's abscess in that case. Here you've got an example of bone replacement, a lucent tumor, well-defined in the greater trochanter. And you might say, well, this is a cartilage tumor of some sort, but the diagnosis here is, in fact, a chondroblastoma. And a chondroblastoma, you say, well, that's not in the epiphysis. Well, of course, the greater trochanter is an epiphysis. So here you've got, again, the site guiding you towards a plain film diagnosis. And in fact, apart from the fact that the CT not showing any particular calcification, the other examinations don't really add an awful lot to it. Bone resorption can be sometimes difficult to see because the replacement, because it can occur under an apparently normal situation. And here you can see the bone loss due to under the well-defined articular surface of the bone. More classic bone loss in the osteoarthritic subchondral cyst, and is as an example. So well-demarcated lytic lesions. There's a list, obviously: bone cysts, enchondroma, fibrous dysplasia, and again, non-ossifying fibroma. And here is a large bone cyst, and again, situated in the metaphysis, but extending into the diaphysis. Some bone replacement lesions may look a little ill-defined and thin the cortex very sharply. Here you see an example. And in this case, the follow-up additional examinations is very useful because it shows these fluid levels, which helps you to a diagnosis of an aneurysmal bone cyst. But the plain film is pretty indicative of that in the age group, in the position, and this expansion and marked thinning of bone. Poorly defined osteolytic lesions are more likely to be in the sarcoma region, lymphomas, metastasis, and myeloma and plasmacytoma. Here is an example of a telangiectatic osteosarcoma, and again you can see the multiple fluid levels on the CT. Brown tumors can be a problem. Here is it because the brown tumors appear in a number of these lists of different lucent lesions, and here is a brown tumor showing you very much a lytic process throughout the bone, but again with areas of well-defined and ill-defined lucency. Diffuse lytic patterns are commonly with metastasis, and here you see this sort of moth-eaten appearance. And in this case, you can see this is a permeative process through the sacrum, through the bone, through the pelvis, and this is an example of myeloma. So diffuse lytic patterns are usually a metastatic or lymphomatous type lesion. Here is a metastasis from which you can see the permeative area and the moth-eaten area within the same bone. So finally, this bone reaction is sclerosis, and here you can, again, this is generalized or focal. And here's a case of generalized sclerosis. Now, it can be very difficult to pick up these generalized lesions because you have to look quite carefully at these to say, are these bones sclerotic? They are, in fact, obviously sclerotic because the differentiation between the cortex and the trabecular bone is lost, and the bone density. But if you've got a well-penetrated radiograph, it may be difficult to see. And this is a case of osteoporosis. So remember, the generalized bone density loss and increase can be difficult to pick up, and you have to be aware of that. Here's an example of probably one of the more common sclerotic lesions, the Paget's disease. And here you see the classic flare appearance of the margin of the pagetoid bone with the normal bone, and the increased sclerosis in the pelvis. So Paget's disease is a common cause of increased density in bone. This patient has metaphyseal increased sclerosis. And you can see that the epiphyses are just fusing, but there is an area of lucency as well. And here the MRI is extremely helpful because it shows you a very marked increase in signal on the stir sequence, confirming that this is an osteomyelitis, a rather more chronic osteomyelitis. But you can really put that diagnosis in the frame, and the MRI from the plain films, and the MRI is really there to confirm that. This one may be more difficult, the plain film again, but in fact you can see the abnormality on this plain film. If you look very carefully, there is one pedicle which looks relatively indefined, a little bit more sclerotic on that side compared to the other, and the CT shows you that this is an osteoid osteoma in the transverse process, base of the transverse process of the body of L3. But the plain film has led you to do an CT in that region. And the MRI simply confirms the edema in the bone as part of the osteoid osteoma process. This example is, again, a difficult one. There is some increased sclerosis in the femoral neck, just there. Patient had pain in the femur, and the MRI shows you the stress fracture in the femoral head with the edema. But the lesion is seen on the plain film. So you haven't gone straight to an MR. You've actually been able to make a probable diagnosis from the plain film. So solitary osteosclerotic lesions. Here's Paget's disease of one of the tarsal bones, and bone islands, necrosis, infarcts, osteoid osteoma, healed bone lesions, stress fractures are all in that list of lesions. One other message to take away is metastases. Metastases can look like anything. So you can have a well-defined lucent metastasis, an ill-defined lucent metastasis, or a sclerotic metastasis. So remember, if you always have metastatic disease in your mind. And here is another example of a patient who has all sorts of little permeative changes, a bit of sclerosis, and you can see the lesion on the CT, but the MR also shows you the skip lesions, this is actually a metastatic disease from melanoma. But the MR is very helpful in these cases because it shows up the marrow so beautifully and shows up metastatic disease very carefully. So if we go now to the cortical outline, always look at the bone. Is the outline intact? Is the outline deformed? Is the cortex sclerotic? And does it compare with the opposite side? Where you have two parts, say something like a pelvis, does it compare with the opposite side? Here is just an example of a patient who was sent to us without a diagnosis from the plain film, had been reported as normal. But you can see, if you look at the sacroiliac joint, the outline is different. The outline of the sacrum is less clear, and the shift of that sclerotic margin compared to the other side. And the CT shows you what really is actually happening. So the CT is vital, but the message is on the plain film. So look at the outlines. Another example here of a pelvis looks pretty good, but look what's happened down here. You just can't see the innominate line so clearly on one side. The teardrop is clearly seen on that side, but difficult to see on that side. That's the MRI, and you can see why there is no lesion there. But the diagnosis can be made, as it were, on the plain film. So always look at the outlines before you, and make sure that you see all the lines that you're expecting. This is, of course, a classic one which can cause considerable medico-legal problems for radiologists. There is the line on that side, and you can see there is a bit of epiphysis above the line. On this side, there is no epiphysis on the line. And this is the later film showing you the slipped femoral epiphysis. So again, outlines, very important to check what the comparison. Finally, in this, looking at bone, the periosteum. Now, there's different reactions to the periosteum. You can get a solid reaction, rather more lamellar, and then, of course, the Codman's triangle, which we're all familiar with, and the spiculated changes. Here is a classic sort of solid lamellar type of periosteal reaction due to an osteoid osteoma. You can see the bone response on the microfocal X-ray of the specimen. So that's the lamella becoming solid. Here is a classic Codman's triangle, and you can see the periosteal reaction, both sides, but it's aggressively destroyed at the margins, associated with sclerosis of bone. Here's a blown-up view showing you the periosteal reaction destroyed. And the MR shows why, of course, that the bone, the soft tissue mass has extended out lifted the periosteum off and broken through the periosteum. So that's the classic Codman's triangle. Another example of, again, diffuse periosteal reaction with a break in the periosteum. Again, this is a Ewing's tumor because of the rather more generalized sclerosis. But the periosteal reactions are common with, obviously, with callus, osteosarcomas, the lymphoma, osteomyelitis, and metastases, and finally infantile cortical and hyperostosis. Sclerotic bone infarction is usually not associated with periosteal reaction. So here you see a big infarct, but there are occasions when there's a generalized periosteal reaction, and this, in fact, is a patient with sickle cell anemia who infarcted the whole shaft of the bone. And it looks like periosteal reaction. It is, in fact, the still vascularized periosteum causing healing of the bone. So the periosteum is actually generating new bone around the infarcted bone within it. So to a certain extent, it's not a true periosteal reaction due to elevation, but it is actually the periosteum healing the bone. Finally, the spiculated pattern of sunburst pattern of periosteal reaction associated with sickle cell anemia, thalassemia, most commonly seen in the skull, but can also be in other bones, and particularly Ewing sarcoma and hemangioma would be a cause of that type of pattern. Whoops, sorry. Osteolytic lesions may contain calcium. Here you see an expanded osteolytic lesion with calcification within the bone. Common lesions for that are obviously cartilage tumors, and this is the one that we tend to think of. But obviously, osteoid osteomas may be more lucent, but with the little central calcified nidus. And sequestrums from the infarcts, as you saw just now, may look like a calcified osteolytic lesion with calcification in them. Here, one final example of what appears to be a periosteal reaction, but this is actually a parosteal osteosarcoma, and you can see that it's actually caused sclerosis, and it's sitting on the surface of bone rather than a true periosteal reaction. So we want to now think about soft tissue swelling. The soft tissues can be a guide to occult trauma, and remember that, always look at the soft tissues. I've mentioned it in Liz Frank fractures. I'll show another example. Associated with infection and particularly associated with inflammatory joint disease. And finally, there are soft tissue tumors, which you must always remember. Here is an example of where soft tissue swelling was absolutely vital. This patient had a cervical spine X-ray, and it looks normal. But look at the pre-vertebral soft tissue line, markedly widened. And in fact, if you look at the plain film, that is not the front of the vertebral body. That is the front of the vertebral body there. And of course, the CT will show that this is a complete dislocation of the cervical spine. So the soft tissue swelling was the key to the diagnosis of this patient. Here is a patient with some obviously periosteal reaction, and you start thinking, well, there must be a sarcoma or something in the bone here, but the bone looks reasonably normal. Of course, if you look at the soft tissue, you will see that there is something here which is more lucent than the normal soft tissue. And the CT will give you the answer. This is, of course, a lipoma close to the bone and actually lifting part of the periosteum away, resulting in bone reaction. So a diagnosis there of a lipoma of bone associated with the periosteum is you can make on the plain film. Again, an example of calcification in the periosteal mass. This is ring calcification, classical of myositis ossificans, and this is, again, another diagnosis that you're able to make from the plain film. So if we then look at arthritis, early development of osteoarthritis, here you can see the 97, and you can see that there may be a little loss of joint space, but very much. Now, in 2002, the joint space is down, and there's some subchondral cystic changes, classical picture of osteoarthritis. And osteoarthritis of the hip is a very common diagnosis for plain radiographs. The surgeons will work off the plain radiograph, full stop. So remember that joint space loss, femoral head migration, in the later stages, obviously collapse of the femoral head, buttressing of the calcar, and osteophyte formation of subchondral sclerosis. Just be careful, though, because sometimes the joint space may look perfectly normal because the patient actually has an anterior osteoarthritic change, and this is more common in patients who have a relatively poorly developed acetabulum. And so you're looking at the joint space at an angle, and so anterior osteoarthritic changes in the hip can be difficult to see. Rheumatoid arthritis, the classical picture is that of peri-articular osteoporosis initially, and then the erosion of bone at the margins of the articular surface at the synovial, where the synovium is associated with bone. The other arthritides, erosive osteoarthritis, the classical picture of the distal osteoarthritic changes with sclerosis and Heberden's nodes, the pencil and cup deformity of psoriasis, and the soft tissue swelling and overhanging of the bone of gout. These are sort of classical pictures which you can make a diagnosis from the plain films. Gouty tophi may appear in rather odd places. Here's one in the knee, but you can see the overhanging appearance of the patella, and there is in here, difficult to see, I'm afraid, but there is in here some calcification, which is not uncommon in gouty tophi. Ankylosing spondylitis can first present with changes in the enthesis, with squaring of the vertebral bodies, and some sclerosis at the enthesis in the lumbar spine. And obviously the diagnosis is made from the sacroiliac joints, and this is a later stage. And one point to make here is that in ankylosing spondylitis, you don't get the same peri-articular edema, the inflammatory edema that you see in some of the other inflammatory lesions, because it is bone producing, and you can see the classic whiskering appearance of the tuberosities. Finally, with cartilage, just to remind you that cartilage is not visible, although you know this. And here's an example of a patient whose knee looks reasonable, maybe a little bit joint space narrowing here, but on the MR you can see the articular cartilage has been denuded. Again, in the children, you can't see the cartilage, so remember that lesions there have to be demonstrated with contrast medium. And again, in this patient, there is clearly a lesion in the epiphysis. This was thought originally to be possibly a chondroblastoma, but it actually turned out to be a Brodie's abscess, as shown by the MRI. Peri-articular calcification, you can see, and this is common in degenerative arthritis, particularly in calcium pyrophosphate disease, and also seen, as we've seen, in gout and hyperparathyroidism and a number of other lesions. And there's the calcification well seen. So, in conclusion, what I've tried to do is show you that radiographs remain a key imaging technique in all sorts of ways, with trauma, joint disease, bone tumors, osteoarthritis, and obviously looking at arthroplasties and follow-up of patients with joint replacements. There are limitations, and one of the key messages is don't try and read too much into the plain film. if you make up stories from the plain film. Use them. You may be able to make the diagnosis straight away, but use them as a guide to other examinations. So be truthful to yourself and the film. They're two-dimensional. There's a lot of superimposition of bone on soft tissues so that they may hide things. There's a limited grayscale. There's poor soft tissue resolution, although don't ignore the soft tissues because they are very important. And the internal structures of the joint are not visible without contrast agents, or now obviously with MRI. And there's a wide differential diagnosis, as I've tried to show you as I go through. But there are key messages there, and there are key lesions which you can pick up if you follow the map and do it logically. So, final message is don't sit there trying to make up your mind and think that is the only thing. Once you've looked at the plain film, decided what the area is, what you think the differential diagnosis may be, then go on to use the complex imaging, which you will hear about in the rest of the course. CT, MR, nuclear medicine, and also remember biopsy may be absolutely vital. Thank you very much for your attention.